So, to start with this presentation, it's a presentation made for my medical English class. I'm Santiago Alarza, I'm a student from the Universidad Católica Santiago de Guayaquil, and my subject is about the lupus anticoagulant and abnormal coagulation of patients with COVID-19. So, to make this clear, we're going to say some definitions about these words on the subject, like lupus, that is an inflammatory disease caused when the immune system attacks its own tissues. Lupus can affect the joints, skin, kidneys, blood cells, brain, heart, and lungs.
Now, lupus is seen predominantly in women. It's 9 times more common in women than in men, and particularly common in African American women. About 1 in 250 African American women develop lupus, and about 1 in 400 or so Caucasian develop lupus. It tends to be seen in women of childbearing age. We say basically 15 to 45, although it can be seen in other individuals as well. So patients with lupus end up with rashes, fatigue, arthritis, but they can also end up with disease of the heart, the kidneys, the lungs, the blood.
So now with coagulation. So it's the process by which the blood loses its liquidity, turning into a gel, to form a clot. This process potentially leads to hemostasis, that is the cessation of blood loss from a damaged vessel followed by repair. So what's an anticoagulant? In medicine and pharmacy, an anticoagulant is an endogenous or exogenous substance that interferes or inhibits the blood clotting, creating an antithrombotic or pro-hemorrhagic state. And what's COVID-19? Coronavirus disease, COVID-19, is an infectious disease caused by a recently discovered coronavirus. Most people with COVID-19 experience mild to moderate symptoms and recover without special treatment.
Coronaviruses are a large family of viruses that get their name from the halo of spike proteins on their outer surface, which resemble a crown, the corona, under a microscope. The new coronavirus is called SARS-CoV-2. SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. As a new virus, it means that previously no one in the world has been infected with it, and therefore, no one has antibodies to it. Because no one has antibodies, everyone is at risk for catching the virus, becoming ill, and spreading the virus. With the discovery of SARS-CoV-2, there are now 7 types of coronaviruses known to affect humans. 4 regularly circulate in humans and mostly cause mild to moderate upper respiratory tract symptoms that most people think of as the common cold. SARS-CoV-2 causes a disease called COVID-19, a severe respiratory illness. COVID-19 can be deadly, particularly for older people and those with underlying health conditions. The virus is spread through droplets in the air after coughing or sneezing, which people nearby can take in through their nose, mouth, or eyes. The virus can also spread by touching a contaminated surface, but it's unclear how long the virus lives on surfaces. Once inside your body, the virus travels quickly to the back of your nasal passages and to the mucous membranes in the back of your throat. The virus attaches to a receptor called angiotensin-converting enzyme 2, or ACE2, on respiratory cells in your body. The virus's genetic material enters your cells. The virus then hijacks your cells to produce copies of itself, which go on to infect more cells. The time between the initial infection and the first symptoms appearing varies widely, but is 5 days on average. Symptoms often start in the back of the throat with a dry cough and sore throat, along with a fever. Symptoms become more severe as the infection starts making its way to your lower respiratory tract. Here, it can cause more respiratory problems like bronchitis and pneumonia. When the
So, what's the important on this subject in medicine? So, in recent research, patients with coronavirus disease have a profound hypercoagulable state, and complicated venous thrombotic events are common in those patients. Abnormalities in coagulation screening measures, including a prolonged activated of partial thromboplastin time, have been reported in patients with COVID-19. Finding could be seen as a reason to avoid the use of anticoagulant at both therapeutic and prophylactic doses.
Welcome back to the Critical Care Survival Guide. Today we're going to be talking about a topic that is very important with regards to COVID-19, and that's coagulopathy. We have been seeing patients come in with COVID-19 disease and they're developing clots. Clots both in their micro vessels inside their lungs. We have data from autopsies when they've dissected them using Lipian. We're seeing both microthrombi clots, but occasionally large clots involving leprosy in the lungs. And as you may have seen in your patients, we're seeing EVTs, pulmonary embolism, and the like. So the question we're going to tackle in today's guide is, why is this happening and what do we need to be doing? So first, why is this happening? COVID-19 covers a ton of information. We're seeing inflammatory markers. The levels are going up. CRPs are going up. Everything is accelerating.
So another really good question, one where there's quite a bit of research actually being put out there, and one that we've already at the Thrombosis Research Group been engaged in trying to look at this. So it looks like COVID-19 has a number of ways that it impacts blood clotting. When patients contract COVID-19, if they suffer a superimposed either pneumonia or other type of bloodstream infection, they have the risk of going into something called disseminated intravascular coagulation, or DIC. And that's a condition that's associated with bleeding. You consume your platelets, it becomes harder and harder for the body to stop bleeding, and there's a hemorrhagic response. That's really one of the most severe manifestations of a COVID-19 infection with a superimposed bacterial infection or systemic inflammatory response. For other patients who suffer from COVID-19, the immobility associated with the virus, or the fact that these patients are being admitted to the hospital and or the ICU, will increase the risk of venous thromboembolism in general. There's some suggestion that COVID-19 may rev up the coagulation process by increasing some of the coagulation response. D-dimers are increased in COVID-19 infection, and so that might be a process where there might be a tendency towards a prothrombotic state. But what we think of for the risk of thrombosis.
So about the process, about this subject, is that we couldn't identify in this research that the patients with COVID had a prolonged APPT, and the most probably reason of it is the presence of lupus anticoagulant in the patient's blood.
Two really good questions. I'll answer the second one first. Patients who are hospitalized with COVID-19 infection are still susceptible to DVT and pulmonary embolism, just like any other sick patient who's admitted to the hospital, and may have risk factors for VTE. So the same precautions that we would extend to any patient admitted to the hospital, screening for DVT risk and provision of any type of a prophylactic anticoagulant will be key. Now, for patients who take standardly or routine anticoagulation for prevention of blood clots, either because they have atrial fibrillation and they're trying to prevent stroke, or venous thromboembolism, or some sort of a mechanical valve, or other indication, you should continue to take your anticoagulant. We have no data to suggest that anticoagulation either prevents COVID-19 infection or places you at higher risk for COVID-19 infection. There have been reports that suggest that taking non-steroidal anti-inflammatory drugs like ibuprofen may predispose to more complicated COVID-19 infections. That has not been shown with anticoagulants, and you don't want to terminate or discontinue taking your anticoagulation because of concerns about COVID-19. All you'll be doing is predisposing yourself to complications of stroke and other types of blood clots. You want to keep taking that, work with your provider. I fielded this question from some of my patients. All the data shows now that it's safe to continue your anticoagulation. You should do it to prevent blood clots, and then practice all of the other important precautions.
So the cons about this is the persistent presence of this lupus anticoagulant can develop thrombotic events in patients with COVID-19. And the LA, that is the lupus anticoagulant, SA contains heparinase, which neutralizes any heparin effect that might lead to false positive detection of LA. So that's the concept about this and the application in our country. I found this in a publication of our government, Healthy. So it's recommended to discontinue any oral anticoagulant upon admission and switch to heparin from low molecular weight or heparin sodium. Another thing is it's recommended before starting anticoagulation in these patients to take into account the function, renal, and adequate assessment of your bleeding risk. And all hospitalized patients measurement of D-dimer, TP, TTP, fibrinogen, and hematic biometry at admission and every 24 and 72 hours depending on the clinical evolution. And the anticoagulation dose should be progressively increased to an intermediate dose and therapy according to risk factors and modification of laboratory parameters. So the conclusion about this is that the doctors should not withhold use of anticoagulants for thrombosis while awaiting further investigation for a prolonged APPTT, nor should they withhold thrombolytic therapy in the face of a high risk of pulmonary embolism on the basis of a prolonged APPTT alone. So that's all. Thank you.